Very good evening, friends, and a very happy new year to all of you. Thank you very much for joining the first international webinar series presentation today. This is the first for this year, 2022, and we have an excellent speaker with us today. We welcome the speaker, Professor Grove. Thank you very much for joining us, and we have excellent sessions lined up for you this year, jointly by CAHO and the International Society for Quality. So let me welcome the moderator for this evening. We have Dr. Nirmal Frederick. Sir is an ophthalmologist. He's the MD of the Nirmal's Eye Hospital, which is at Tambaram. He's a principal assessor for the National Accreditation Board for Hospitals and Healthcare Providers, executive committee member of OTSI and member legal cell AIOS, mentor advisor to the Tamil Nadu Ophthalmic Association, Journal of Ophthalmic Science and Research, chairman of the academic committee of the IMA, vice president of the TNOA. He has received several awards. He's an excellent speaker, and we welcome you, sir, today to moderate the session. And I'll hand over to you, sir. Over to you.
Thank you, Dr. Lalu and CAHO for this wonderful opportunity. And indeed, patient-centered care is the heart of all our quality initiatives and all our associations. And all said and done, the entire healthcare system revolves around patient. And he should be in the top of the pyramid. So whatever we do, the patient has to be in full control. If he is in full control, our system and patient satisfaction and outcomes also will be in full control. And if the focus is on, I'm an ophthalmologist, I know the value of focus. And if we have one focus, that is patient, we can have better outcomes, safer environment, fewer medical and medication errors, fewer patient falls, lower cost, decreased length of stay, and increased patient satisfaction. So this sums up the entire quality management system in healthcare. And so this webinar is aptly the first webinar for this year. And we also have a person of stature of Professor Dr. Berntsen, who is a professor at the Norwegian Center for E-Health Research. She has worked in the field of e-health since 2009, and she researches technology-assisted quality assurance, patient pathways across care boundaries, integrated care, and person-centered care for patients with complex and long-term needs. Healthcare has almost 40 to 50% of patients with complex and long-term needs, and this topic is very important to take care of such people. She was research director of the Center of Clinical Documentation and Evaluation, and which was awarded a national role as a steward of national clinical registries. She has a PhD in osteoporosis and was licensed as a medical doctor in 1994. And she also holds a teaching position at the Department of Community Medicine at the University of Tromsø, Norway. And her institute, Norwegian Center for E-Health Research, is doing a tremendous job. You can see the infographics there, over 142 projects, 1,863 publications, and these 34 fact sheets are a treasure house. I urge people who are attending this webinar to go through these reports and fact sheet to get a full view of what the institute is doing. And it's indeed a pleasure to welcome Dr. and Professor Berntsen, and it's apt that she has done a lot of work on this topic, and let's listen to her and her experience. Professor Berntsen, welcome to CAHO. We look forward to your talk. Thank you so much.
Thank you so much for that very warm introduction. I'm going to start by sharing my slides, and while I'm doing so, I'd like to also say Happy New Year to all of you. And it's such an honor to be with you today and to be allowed to talk to you about this topic that is so dear to my heart and that I am really passionate about. I want to say that I was invited to work with you through ISQua, the International Society for Quality in Healthcare. And I thank them for making this possible together with you. And I'd also like to say that what I'm saying today is based on a work that I've done together with the ISQua Person-Centered Care Group, which consists of members from all over the world. We started this work for about 2 years ago, and we have, because of Corona, not been able to meet in person, but it's still been a very interesting and passionate journey for all of us. I'm not going to go through their names. You can see them all here, and I'll share my slides with you afterwards. So the mission of our group was to draft a white paper on person-centered care for ISQua, and that white paper is currently up into a review process. And I hope that what comes out of it is a white paper that can be a guidance to healthcare managers and healthcare professionals and patients all over the world. And we set out to build awareness, knowledge, and reflection on why is person-centered care important? What is it actually? And how can person-centered care become a design feature of our care systems? Now, I could probably talk about this topic for days on end. And so what you will be served here today is just a small piece of what I think is most important. And hopefully that will make you more curious to follow up on some of the challenges that I will give you or that are in this field. So I always like to start with stories. I think stories are a great way of communicating why something is important. So this is a story of Robert that's been published. It's anonymized, of course, by some authors that have looked into the story of a person who is HIV positive, and he has dropped out of his antiretroviral therapy program or ART program. And as most of you probably know, ART is a lifelong treatment. And if you drop out of your treatment program, you're actually at risk for dying of AIDS. So it's very important for both the care system and the patient to follow up and follow through on the ART program. Yet, up to 1/3 of HIV patients are lost to follow-up, even when care or the treatment program is free of charge. And so this research project tried to figure out why do these patients drop out. And Robert's story is just one of many, but it illustrates some of the challenges that healthcare systems have. And I want to underline that in this work, we've seen that anywhere where modern medicine has taken hold, we see the same challenges. They exist all over the world. It is not any better in any part of the world, as far as we can see. Maybe it's better in India, I hope so, but I suspect that also the Indian system have the same challenges as the European, American, African, and South American areas of the world. So here's Robert's story. He says about why he dropped out of his ART program. He said, you know, sometimes it's difficult to get vehicles. And when you go to look for money for a motorcycle or a taxi, you find you don't have it. So when you miss your appointment and go to the clinic on another day, the provider starts quarreling with you about not having come on the appointed day. And when you tell that person that you got problems, he tells you, you should have spent the night on the road. So how can I spend the night on the road? Here I am. I have failed to get money for taking me to the hospital. And then I'm supposed to get money to spend the night somewhere and feed myself. These are some of the problems I have in going to the clinic. Now, the researcher doesn't give up that easy and says, but challenges Robert and says, but still, why didn't you come back despite what happened to you? I mean, this is important. You should have come back to the clinic and met with some other health professional. And I told her, no, I didn't want to show up because what happened to me was still in my heart. If I had been treated nicely, the situation would have been different. Since I was treated badly, I saw the treatment was meaningless. And so this is an illustration of a person that feels disrespected by some professional in a care system, probably a stressed out professional who had many good reasons to be snapped, and yet it has this devastating consequence for this person who just feels he can't take it anymore, which is this is really easy to sympathize with and empathize with it. We shouldn't have situations like this, and yet we have data that shows that abuse or mistreatment of patients actually happen all over the world. Here is a qualitative study that's been published in PLOS Medicine, which is a systematic review of 65 studies from 34 countries, exploring the experiences of women who give birth in healthcare facilities. And the reports of abuse that arrive here are actually quite astounding. And so this is a system challenge, and it's a system challenge that goes across all over the world. Here is another study that documents the same, where women find that 90% women in maternity wards report that 90% of the providers, 90% of the women report that the providers never introduced themselves, and providers never asked permission before performing medical procedures. And here is an example from my own country. She's a little bit more, she explains a little bit more how she sees the healthcare system from both sides, because this person has worked as a nurse for many years in the public healthcare system, and now she's a cancer patient in her 50s. And she writes a letter to her oncology department, and she says, "Now I feel like I'm put on the sideline, having to fight two battlefields at the same time, against the system and against the cancer. I'm afraid our next meeting will not allow the time or the possibility for discussing anything but the medical and technical themes. I'm afraid of being seen as difficult and making incessant complaints, afraid of not getting a chance to express myself and have a real interhuman contact." So from all these stories, and there are many more out there that, and I'm sure that many of you also have examples or have experiences that are in the same vein, we can maybe summarize the challenge like this: that healthcare is not able to, for some reason, to pay sufficient respect to the individuality and human dignity of the persons who seek help from them. And there seems to be a conflict, a tension between providing excellent technical care and being able to be connected and empathic and sympathetic towards the person who is seeking care from us. So I'm not going to argue anymore for why person-centered care is important, except I hope that these stories speak to your hearts, that we should be able to provide both sympathetic person-centered care and excellent technical care. There is no tension really between them. So if we want to deliver person-centered care, we really have to know what is person-centered care. It's easy to recognize what it isn't, but what is it really? And that's been a huge challenge. And there's been many reports over many years. The first report on that calls for more person-centered care that I have found was published already in the 1930s. Here is a report from the Health Foundation in the UK, where they say that there is actually no single agreed definition of the concept, and this is still an emerging and evolving area. So we can easily recognize what person-centered care isn't, but recognizing what it is still difficult. I like this definition that's recently been published by the American Geriatric Society expert panel, which has 2 points to it. It is, one point says what person-centered care is, and the second point says something about how to achieve person-centered care. So they say that person-centered care means that individuals' values and preferences are elicited and once expressed guide all aspects of their healthcare, supporting their realistic health and life goals. So person-centered care here is identified as exploring values and preferences and sticking to those as a guideline for our care decisions. And then how do we achieve that? And here they give us this advice: person-centered care is achieved through a dynamic relationship among individuals, others who are important to them, and all relevant providers. So it's actually a team effort here. It's the patient and it's the professionals, and there are also the others that are important to them, and they collaborate to make informed shared decision making to the extent that the individual desires. So shared decision making is also a key term here. In our work on person-centered care in the group that ISQua that I've worked with in the ISQua context, we like to start with this image, because every patient is a person who has a background, and that background and the life context defines what goals they're striving to reach in their lives, what matters to them. And if they have a health challenge that is a threat to that goal, then the patient journey is the way the patient, together with the healthcare system, gets to work towards that goal, what matters to you. So in our having this picture of the patient journey and the patient's life goal as the bigger framework, healthcare's role then is to support the person on their patient journey towards goals that are meaningful to the person. So with this picture in mind, our group has latched on to many of the same concepts that the American Geriatric Society has, but we have emphasized the role of the patient journey. So to us, and to me, person-centered care is a sharing of power so that the answer to what matters to you drives care decisions. And then patients and professionals co-create the patient journey in order, within the constraints set by the care system, to reach those goals that are meaningful to the patient. So that's what we think patient-centered care is. So if we know that and you know, the rhetoric for patient-centered care is very strong in most environments. There is no manager, no healthcare decision maker, no health professional that would ever say that I am not patient-centered. We are all focused on and wish in the deepest of our being to support patients on their journeys towards better health. So this is a bit of a paradox. If this is so important to us, and it's in every white paper, in every management document, and yet we have these reports from patients and we have these documentations that patients actually feel abused in our care systems, why is this so? Why is person-centered care so difficult to achieve? So it's been my, that's been the bigger challenge in this work, is to understand why person-centered care is not the norm. And if we don't understand that, we won't be able to succeed in strengthening person-centered care. So the answer to this paradox, I think, lies in this sentence here, because we tend to behave in line with the system goal. Now, what is our healthcare system goals? There's what we say the goal is, and then there's what our behavior says the goal is. So let's explore this a little bit further. What is the healthcare system goal? If we look to the WHO, the goal of healthcare systems is to improve the health of the population it serves. So that seems straightforward, but let's look at the word health. What is health? So again, WHO, which in my mind does an excellent job here in defining health. They say that health is a state of complete physical, mental, and social well-being, and not merely an absence of disease or infirmity. And then in 1986, they expanded this decision to say that health is therefore a resource of everyday life and not the objective of living in itself. And health is a positive concept, emphasizing social and personal resources as well as physical capacities. So there's nothing in the definition of health here that constrains us only to deliver technically excellent care. The definition of health actually includes the life perspective that we're saw also in the definitions of what person-centered care is. So that's not the answer, that health is understood as too narrow of a concept. So, but how does a care system improve health? Well, the micro unit, the smallest unit where the care professional and the patient meet is in the consultation. And in the consultation, there are two people present. There's the professional and there's the patient. But I want to emphasize that even though there are only two people, there's always a third party there, and that is the system. The professional is always part of a care system in some way. And the care system consists of many frontline professionals and mid-level decision makers and top-level national decision makers. And the patient, if that patient has most conditions today require maybe more than one meeting, and often that patient then will meet with more than one representative of the care system, and there will be many professionals that meet the same patient. So the patient quickly understands and experiences that the consultation is maybe part of the journey, but it's not the journey itself. So if we now have decomposed the care system in this way, in roles and structures, the process that we serve, and the outcomes, the desired outcomes that we have in our care systems. There is the person with a health challenge, and the blue line represents that person's life course. And then there's the healthcare team, and the red line represents the healthcare team's development over time. And then, as said before, the healthcare team is always supported by a care system and a payer. And now the patient journey that we saw in the patient-centered care between system and professionals. Sorry, between the patient and the professionals, and the outcomes that we desire from this process. I like the quadruple aim outcomes. For the patient, is the patient experience and improved health and function. For the professionals, it's the professional satisfaction. And for the care system / payer, they'd like to see a good cost-benefit ratio. And I think that we can't think of person-centered care without understanding this background here, because the three roles that are always present in every patient journey all matter. And each of the three roles, the payer, the patient, and the professionals, they have slightly different goals on their way towards better health. The patient's goal is clear. My health is a resource for my life. I want my health to support me in whatever I want to achieve in my life. For the professionals, however, the goal is to serve and improve health and function of our patients, and they're not necessarily concerned with the life perspective. And then the care system / payer, they are tasked with to serve and maintain and improve health at the population level, and are perhaps the furthest removed from the life perspective of the patient. So here we have these three different goals that all impact on what we're doing while we're providing care, because the professionals are set in a context of the system, and the system requires them to do and behave in certain ways. So here, there is the clash of two lines of logic. There's the goal of the person, And there's the goal of the system and the professionals. And the system and the professionals, they want to see technical excellence of care. They want to see good cost-benefit ratios. They want to see outcomes that are defined by professionals. And there is a logic here, which does not really include the volatile, fluid, and difficult to define personal preferences and values and needs of patients. Whilst the patient, there, on the other hand, is the owner of their body and health, and they have a right and duty to take care of their health, and they need support in taking care of their health within their context and their life project. And these two ways of thinking don't always meet in a good way. So my answer to why is person-centered care so difficult is that because patients are a more fragile voice, and because the patient voice has less power, it has less money behind it, we as a system players pay more attention to the professional and system values than to the patient values. So that might be one way to respond to that is, okay, so that's how it is. And do we really have to do something about this? So here's a take on why it is so important also for the system to act and create a more person-centered care system. Because historically, we've built healthcare systems to act on emergencies. And in emergencies, the profession-centered, system-centered way of acting, where we act on behalf of the patient, where the patient is seen as a more passive recipient of care, is is part of the historic background that led us to the current healthcare design. But in the future, the number of elderly, the number of patients with long-term healthcare needs will be growing. It is growing all over the world, both in developed and low and middle income countries. And when your healthcare needs are long-term, it's more the need to act together with, and the need to act in concert with, and the need to bring out the patient resources becomes much stronger. So we're moving away from a situation where emergencies are dominating our healthcare reality to a situation where long-term needs are much more important to be able to respond to. Populations are growing older, and this goes for all parts of the world. And in 2050, 10 to 30% of the Indian population will be over 60 years or older. And here is some statistics from India, which shows the change in mortality and disability statistics from 2009 to 2019, over 20 years. And you can see that all the neonatal disorders, the diarrheal diseases, the lower respiratory infectious diseases are decreasing, whereas the increase is seen in ischemic heart disease, COPD, tuberculosis, diabetes. These are long-term conditions where we have to work together with patients in order to achieve the results that we wish to see. And again, another statistics that is the same in every healthcare system that has been examined. If you look at healthcare spending and divide the population in 3 tiers, the 10% that spend the most funding, the 10% top spenders, they are characterized by chronic condition, multimorbidity, and a high mortality rate. And if you look at their costs, 2/3 of their costs go to this complex group. So the long-term healthcare conditions are going to be dominating our economy and our budgets, and we better get this right and do this the right way. And one of the ways in which we can reduce costs, improve outcomes, is to work together with patients on how to improve their health. So sustainability is a huge component for why it's important to work on person-centered care. So if this is so important, then both at the system level and at the individual level, how can we change? And I don't think we can answer that question without looking to the word complexity. Healthcare systems are complex, and understanding complexity is central to what we have to do. There is no simple fix in changing our way of behavior. So very briefly, I'll run you through complexity theory. A simple problem is one where the cause and effect is well known and there's no discussion about what to do. Cardiopulmonary resuscitation in the case of a heart attack is an example of a simple causal relationship. We know that if someone falls over due to a heart attack, we start with CPR. The standardized pathway is an example of a complicated problem. It's a problem where there are many decisions to be made, but they can be made if you know your field well and you know how to assess the issues at each decision point. And there can be, for a standardized or a complicated issue, there can be guidelines that say that if so, go in this direction, if not so, then go in this other direction. So we get these complex decision trees that guide us in how to care best in the best possible way for our patients. Now, for complex challenges, you cannot create such a standardized pathway. And a very good example of a complex challenge is childcare. And no one would try to create a standardized pathway for bringing up a child, because what you have to do in a complex situation is understand what the problem is, and then you have to trial different possible solutions and see if what works. If a baby is crying, it might be hungry, it might have a full diaper, it might it might have bellyache, it might be underslept. And you just have to try each of those solutions and see what brings you to the goal. And so in complex problem solving, you try to discover which road fits best with the goals that we're trying to reach. So it's a iterative trial and trial by and fail and try to choose your path forward by trial and fail procedures. And then the last part of a complexity theory is chaos. In chaos, all rules are off. War is a typical example of chaos, and hopefully we're never in total chaos in healthcare, but maybe in catastrophes and big crises, we do have chaos. But mostly I'm interested in the complex problem solving scenario here. So bringing that with us, in complex systems, the iceberg model kind of describes how what the drivers are behind the events that we see. So the iceberg model says that you have events and patterns, which is what we described in the beginning of this talk. The events and patterns are what is visible to us. This is where Robert stops attending his art program, or mother feels disrespectfully treated. This is what we can see. But the drivers behind those patterns are the systemic structures and the mental models that we have of what we're about. And these elements, they are stable, they're interconnected, and they're linked to a purpose/function. So understanding how to change our care system to be more person-centered, we have to work with these systemic structures and the mental models of our care systems. And this is where I go back to our 3 roles. Currently, we have a mental model where the payer/governance and the professional values dominate what we do. I'm not saying that we don't ever listen to patients. I'm very clear that most professionals do when they can, but it's not an always event. So what we want is to change this and make a hierarchy where the mental model is that the patients, what matters to you is at the top of our goal hierarchy, and the professionals, their role is to serve patient goals, and the system's role is to serve professionals in their capacity of serving patients. And notice that what I've done here is not so much to change the system, but just to change the hierarchy between the goals of these 3 roles. And I'm saying explicitly that what matters to you in the patient role is what serves to guide us in everything we do. So how do we get there? Changing the mental model is not done in a moment. And I think that we have to work explicitly in changing our language and making that the goal of the patient quite explicit and visible in our care system. So a new language is paramount. We need to document and we need to make information flow that makes the new mental model tangible. So in the new mental model, we need to understand who is the person. We need to document more of who the identity of that person and how whatever health challenge they have, how that affects that person. We need to document what matters to that person and translate that into goals for care. And then our role in the patient journey is to help the patient get to the goal. And now the patient is the active person, the patient is the traveler. Professionals are travel agents. We tailor the journey to the traveler, and we try to make the journey meaningful, feasible, and as comfortable as possible. And in order to do this, we need to do this better. We need new feedback loops. We need to check on our progress. So that means that registering and looking at how do we record what matters? What is the goal? Did we meet that goal? If not, what can we learn from what's been done and how can we change? And then for each episode of care, we need to look at how are we listening to our patients and are we achieving shared decision-making? And that can only be observed if we ask our patients directly. And then, of course, a patient journey is made up of many episodes, but there is a link between those episodes. So the series of events need to be looked at together as a journey. The gaps and was there gaps? Were there discontinuities between the events? Were there any challenging events? Were there events that were contradictory? I also want to underline that many of the definitions of person-centered care bring into the loop the need for integrated care. And I want to make a distinction between person-centered care and integrated care. Person-centered care leads to integrated care, but they are not the same. So if you have one overarching goal, which is defined by the person, that is a goal that all the health professionals across the different organizations and across different professions, it will have a coordinating effect on those professionals. So what matters to you and how to translating that goal into sub-goals for each of the roles in a patient journey has the effect that it automatically integrates care towards the overarching goal. And also, person-centered care is not the same as proactive care, but person-centered care leads to proactive care in the sense that the person owns their own care. They're their main agent of self-management and self-care, and that is one of the main determinants for good outcomes. So professional services support patients in their self-management, and self-management is always proactive, looking at what are the risk factors and how can we help patients work with their own risk factors to get the best health and outcomes that they wish for themselves. So I wanted to go a little bit deeper because I've now gone through the concepts and the principles, and I wanted to give some tips for the measurement and documentation of person-centered care. And this is a form that's very, very simple that I think might help us to document what patients want from their healthcare systems and from their patient journey. And it actually centers on the question, what matters to you? Now, I want to underline that what matters to you, that question is not a method, it's a concept. There are many ways of asking this question, and patients often don't have goals at the top of their mind. And you might want to reformulate what matters to you into what do you see for yourself when you come back to your home? How did this happen? Start a conversation with the patient on what their experience about their healthcare issues are. This form asks the patient to outline what their health challenges are and how difficult it is for them at the current situation to achieve or overcome their healthcare challenge, and trying to measure how successful we are in meeting what the person, him, herself, outlines as the main issue. You can have them use this visual analog scale and say that, is there a high difficulty or no difficulty at all, and then choose a number on this scale. And here is the first probing with the patient, and here's the second probing 3 months later. And you can actually then measure quantitatively the experience of change using this tool. Now, another lady that has worked with the documentation of goals is Emma Miller. She has led a project that's in Scotland that's called Meaningful and Measurable. And there she doesn't use quantitative data at all. She only uses language or qualitative data. And what she encourages healthcare workers and social workers to do is to start with what matters, explore what matters, and plan ahead together with the patient. Start doing what they have planned together, and then evaluate. What did we achieve? And then learn and develop and change if you're not achieving what you thought you would achieve. There are other tools that will help you assess how well you are doing shared decision making in a given consultation. This is the Collaborate tool. It consists of 3 questions that you can give to your patients after the consultation, and it will help you understand how well the patient felt he or she was included in their decision making. There is the consultations outcomes rating scale, which is also a validated tool for assessment of the consultation. And then finally, I want to underline that the patient narrative is also very useful. And narratives are particularly effective in raising issues relating to values, morals, emotions that might not be accessible otherwise. And it's also very useful in encouraging more person-centered awareness. And finally, stories. We live and create meaning through stories that link past, present, and future in a way that tells us where we have been, where we are, and where we could be going. And I think that discussing stories with our patients would bring out to a much greater extent the experience of being on that patient journey, and then in turn allowing us as professionals to meet them at the spot where they are. So that was actually what I had planned to talk about today. This has been a great experience of the year, and I hope that there are both many comments and questions for me.
Thank you, Professor Groh. It was a wonderful talk on patient-centered care, and it was really a journey for all of us, taking from the basics to the system goals, and then the transition and change the two lines of logic. So you covered the entire gamut of patient-centered care. Thank you so much for the wonderful lectures. I think your lecture was too clear. There are not many questions in the Q&A box. There is one from Dr. Samina. How do we create time for team to invest in your tools for patient-centric approach?
Can you say that again? How do we create time? Yeah. Okay, that's a very good question, and that's one that I've been asked many, many times. And I want to underline that I believe deeply in my heart that patient-centered care will actually save time. But I understand also, with the pressure that we have as professionals to do the right thing, make the right medical decisions, make the right calls, and doing the technically excellent thing, that we would feel that making that conversation about the fluid life context of the person might steal valuable time from that the technical areas of our work. Technical is perhaps not the right word, but I think I'm conveying the right sense here. If, like everything else, you have to train. You have to try and train and try again. And if you do this systematically, you will find that you will gain so much information from the dialogue with the person that you will actually not spend more time. There's a lot of documentation showing that doctors stop the patient from talking at about between 7 and 14 seconds, and we lose information when we do that. We think we're taking control, but in fact, we're not allowing the person to come out with those little tidbits that will help us guide us in making the right medical decisions. So, and the other part of the equation is, if we only focus on the technical and not on what's important to the person, how can we believe that the person will actually know how to take care of themselves when they leave the consultation? If we change our perspective from being we are the ones who provide the right technical care to the person is the one who has to provide care for themselves, and we are the support team, then maybe this picture can change. So short answer, it doesn't take more time. There is documentation out there that says that. I understand why you wouldn't perceive it as that way. And you have to practice to make that come through. And I think that's actually a topic for a whole new lecture on how to practically go about it.
Yes. There's another question, how to begin the promotion of PCC at organization levels? Because most of them are administrators, they have set the systems. So it's difficult to change from that service-centered or organization-centered to patient-centered.
And isn't that such a great example of the ambiguity here? Because at the decision-making level, all decision makers will say that they want their care systems to be person-centered. But when you look at the mechanisms they use to guide professionals, there's very little incentives and tools to make person-centered care happen. So it's essential that our decision makers both say not only the rhetorics, but that they change the the way in which they guide our professionals. And I think the biggest message here is that person-centered care is more effective, it's more sustainable, and we are beginning to get data that shows that. Will be the first to admit that the data is not complete. We are still struggling with the hardcore data that shows that person-centered care actually delivers better results in terms of economy, but it certainly delivers better results in terms of outcomes, which is why we're here. We're not here to make a profit. We're here to make good outcomes for our patients. So make your decision makers look into the sustainability part. That's where the carrot is for them.
Question from Dr. Saurav Maiti. Does patient-centered care violate the uniform hospital services to its patients?
Violate the what? Coming in?
Does patient-centered care violate the uniform hospital services to its patients? I think what he means is when you are focusing the care to patient needs, there's also one standard requirement that hospital services has to be uniform.
Right, right. And by uniform, I'd like to think of that as standardized care, where you follow evidence guidelines and where we achieve excellent care through standardized evidence-based care. And my answer to that is, to a certain extent, it would violate standardized care. But in my opinion, evidence-based medicine, and also in the opinion of Sackett, that actually introduced that term, evidence-based care is a combination of what the science tells us, what my experience as a clinician tells me, and what the experience of the patient is. And the care that you provide is actually it comes together from those three perspectives. And so I think that it would never be right to just dispense of evidence-based care or standardized care like it was a checkbook. You always have to use the guidelines as a guideline, not as a law. It's not a law book, it's a guideline. It tells you, here are the things that you should be thinking about, and now adapt it to the personal situation of your patient. And so for me, evidence-based care is actually that adaptation process. And that is the art of healthcare, the art of medicine, the art of any health professional actually.
Thank you. I think that also answers the next question. Is informed consent for any procedure comes under the ambit of PCC?
We always work under the assumption of informed consent. We can never do anything with anyone, for anyone, without their consent, unless they, for some reason, by law, we have needed to replace that consent with support from someone else. Children, of course, they need their guardians, and patients with dementia, patients with mental health issues, there are rules in place to put guardians there to help them and support them. But in essence, we always have to have the patient's informed consent to do anything. And now I believe that everyone knows that, and yet we, because the patient voice and the patient position is fragile, the patient power balance, the professional is the powerful one. So even if we know that, and even if we know that we can't do anything without their consent, there are many ways in which we can force ourselves on patients because they are in our power.
Yeah, thank you. I think a couple of questions more. Any workable or achievable models to PCC? Or I would rather rephrase it. So we all are oriented to a system-oriented approach. And how do we transit or make the change towards patient-centered care?
Well, I wish I had a short and easy answer to that. I don't. I think that what we need is to change our mental model And we need to do that explicitly, and we need to do that in the regulatory and financial incentives. Everything we do at the system level needs to be aligned with the 3 roles that actually make up care. And all 3 roles have legitimate concerns, but the patient voice so far has been neglected. The professional and the system voice are well taken care of. So bringing the patient voice, bringing the patient perspective into everything that happens, regulatory, information flow, organizational structures, and financial incentives, those 4, and maybe 5, the educational area. Bringing the patient perspective into everything we do is actually necessary to make this happen at the system level. And no, I don't have a ready-made model. We do have some examples that are quite successful. I'd like to point to the South Central Foundation in Alaska that has taken a very strong position in protecting their Native American perspective, and through that become a very person-centered care organization. There's the Kaiser Permanente in the US that's been written a lot about, and there are probably many more that I don't know about. And so this is an area of development. It's an area where research is difficult because it has to be done on system level, and you can't do experiments at the system level. So, and I hope that all of you help push, pull wherever you are in making these changes happen, because I think they're so important.
Yeah.
Professor Groh, once again, thank you very much. And I invite Professor Jagaswati to do the honors to present you with the virtual certificate. Over to you, Jagaswati sir.
Thank you, Professor Groh. It was a pleasure listening to you. You gave a very lucid presentation of a very complex topic. And if there's one take-home message I think most people will take from this lecture of yours, was that the system and the professionals serve the patient. The patient is at the top of the pyramid. And I think if we remember that all the time, we won't go very far wrong. Thank you so much. And it's my pleasure on behalf of CAHO to present this certificate of appreciation, and maybe a virtual bouquet of flowers as well.
Thank you so much.
Thank you.
Thank you, dear participants, once again for joining us.